So I've got an extra 2 minutes because I finished early. Right. So I think it's interesting to reflect that the basic technique for creating a surgical fistula hasn't really changed since it was first described in the 1960s. And with a surgical fistula, we attach an artery to a vein and we divert all the flow into that vein. But within the last few years, there are now devices that allow an anastomosis to be formed between the radial artery or the ulnar artery deep within the proximal forearm and its adjacent vein. So flow goes up through a perforator into either the basic system, the cephalic system, or both. There are two devices that are able to do this now. There's the Wavelink and the Ellipsys. The Wavelink system consists of two full French catheters. The arterial one is positioned in the proximal radial artery or the proximal ulnar artery, and the other one into the adjacent vein. They've got powerful magnets on the catheter which essentially cause the catheters to stick together, and that orientates the electrode. They can be inserted in the wrist and pass proximally, or into the brachial vessels and pass distally. And once positioned, the radiofrequency probe or radiofrequency pulse is fired. That cuts and seals an anastomosis and creates the fistula. And this is all done under radiological guidance, and only small volumes of contrast are needed. As you might imagine, planning is key to this, and with regard to the Wavelink system, you're looking at it needing a cephalic vein or a basic vein that's 2.5 millimeters or more. Where the fistula is created, the radial or ulnar arteries and the adjacent veins need to be at least 2 millimeters in diameter, and those veins need to connect to a 2 millimeter or more non-tortuous perforator, which then connects to either the cephalic veins, basic veins, or to both. The Ellipsys system, planning very similar, but this is all done under ultrasound guidance. So a needle is passed into a vein on the antecubital fossa. It's then gently guided down the perforator, and the proximal radial artery is cannulated. The 6 French Ellipsys system is then inserted, and then through a combination of pressure and heat, the anastomosis is formed. Most people now gently dilate it, and the fistula is created. Both of these systems create the fistula in the proximal forearm. So flow can be into the cephalic system, into the basic system, or both. This patient has very prominent veins, but typically the veins are not as prominent as with a surgical fistula. The thrill is less, 𝗔 is less. And therefore, the cannulation site needs to be carefully planned. So you need to do an ultrasound post-creation to work out which veins are carrying most of the flow. Because it might be you put 2 needles in the cephalic vein, it might be 2 needles in the basic vein, or it might be 1 in each. So how does it work? If you take all the patients coming for an assessment for an upper limb access, then about 30% of them are suitable for endo AVF, although the estimates do vary. Of those who are suitable for a surgical AVF, then about 60% of those are suitable for an endo AVF. Technical success rates are quoted to be very high. Maturation rates very high, although some of the definitions for maturation I think are quite generous. I think that reflects that 2-needle dialysis is possible in about 60 to 95% of patients. Reintervention rates vary enormously. They tend to be embolizations, typically of the brachial veins, that divert flow up the perforator superficially, balloon angioplasties of stenosis near the perforator at the anastomosis, and surgical superficializations, typically of the basic vein. Patency rates are as you see them there, but we're thinking, well, how does an endo AVF compare to a surgical AVF? There's no randomized data yet, probably never will be. This meta-analysis came out this year and found there was no difference in the time to 2-needle cannulation, nor the secondary patency rates between endo and surgical AVFs. But there was a benefit with endo AVF at needing less future interventions. So, how does it fit within our sort of current access ladder? I think it should come in. I think it's being used after a forearm fistula, because it doesn't preclude the use of or the creation of a brachiocephalic fistula or a BVT fistula in the future if that's required to keep that access working. So in summary, it's a promising new technology. I think they're encouraging results, but it's eye-wateringly expensive. And I think it's still finding a place in the treatment algorithms in many centres. Thank you very much.